For this presentation, our group will be discussing hip injuries among older adults, specifically hip fractures, piriformis syndrome, and hip dislocations. Hip injuries among this population are important to study due not only to their frequent incidence, but also because of their potential to result in decreased functional capacity and quality of life, as well as causing increased medical expenses. My name is Kaitlyn Springer, and in order to discuss the disordered hip, I will first be establishing the joint's typical and healthy structure and movement. Bones relevant to the hip joint include those associated with the pelvic girdle and femur. The pelvic girdle is made up of the two hip bones called os coxae, as well as the sacrum, which serves as the hip's posterior connection to the axial skeleton. The three segments of the os coxae include the ilium, which is located superiorly, the ischium, which is located posteriorly and inferiorly, and the pubis, which is located anteriorly and inferiorly. The ilium, which is represented by the light gray color in this image, has a curved shape and has several bony landmarks that are important attachment points for tendons, such as the gluteal lines, as well as for important nerves and blood vessels to pass through to the legs, such as the greater sciatic notch. The ischium, which is pictured in the pale pink color, is a small portion of the hip, and its tuberosity serves as an attachment point for many of the hamstring muscles. The pubis, which is shown in bright pink, connects the two halves of the pelvis on the anterior side at the pubic symphysis. Together, the ischium and pubis encircle the obturator foramen, which is an important attachment site for many of the hip muscles involved in external rotation. The illustration on the left side also depicts the acetabulum, which is a concave spot on the lateral side of the hip where the head of the femur articulates. Generally, there are key differences between the proportions of the average female's pelvis when compared with a male's. These are mostly because females' pelvises are adapted for pregnancy and childbirth, whereas males are typically taller and do not need the structural adaptations for birth. So the images on the left side show a typical male pelvis, and the two on the right side show a typical female's. The female pelvis is wider and shallower, almost like a bowl, and it is designed to hold a developing fetus. But the male pelvis is narrower and deeper. The femur, which is also known as the thigh bone, articulates proximally with the hip joint at the femoral head and distally at the knee joint with its medial and lateral condyles. Its bony landmarks, such as the greater and lesser trochanters, which are shown superiorly on the anterior view, as well as the linea aspera, which is on the posterior view on the right, both serve as insertion sites for many of the muscles that originate on the pelvis. And in a healthy hip, like this one that's pictured, the femoral neck is intact and connects the femoral head within the hip socket to the shaft of the bone below. Next, I will cover the hip joint capsule. And there are three major capsular ligaments that surround the hip joint and provide it with stability. The first is the iliofemoral ligament, which is abbreviated ILFL in this image. And the second is the pubofemoral ligament, the PFL. Both of these are shown in the left picture on the anterior view. And then the third is the ischiofemoral ligament, abbreviated ISFL, which is shown on the right picture on the posterior view. The iliofemoral and ischiofemoral ligaments are both subdivided into superior and inferior bands, which adds an SB or IB to their acronyms, which are shown in this image respectively. At various points throughout the hip's range of motion, the capsular ligaments that envelop the hip joint allow more laxity or are more restrictive depending on how the hip is positioned. In a healthy hip, the capsular ligaments provide a great deal of rotational restraint when the hip is approaching the extremes in its range of motion, such as in high degrees of flexion, extension, abduction, or adduction. However, in more normal ranges that are utilized in daily life, such as mid-range of flexion, abduction, and adduction, these ligaments provide quite a bit of slack so that normal movements are not inhibited. The image on the left shows how the supporting structures of the hip encircle the acetabulum and the femoral head to provide stability. The green, purple, gray, and orange on the left image represent the proximal attachment sites of the capsular ligaments that we talked about in the previous slide, and the brown color represents where the fibers of the articular capsule surround the hip joint. And the illustration on the right depicts how the labrum rests within the hip joint. On average, the labrum is only 2 to 3 millimeters thick, but it plays important roles in upholding the integrity of the hip joint and allowing it to move safely. Also, it reduces friction within the articulation of the hip because it keeps the synovial fluid contained inside the joint capsule. And because the collagen fibers that make up fiber cartilage are relatively stiff, the labrum's shape helps to maintain the proper alignment of the ball-shaped head of the femur within the socket of the hip. Next, I will discuss the muscles of the hip, and there are 5 major groups of muscles associated with the hip, including the anterior, medial, and posterior compartments, as well as the lateral rotators and gluteal region. The illustration on the right displays the anterior and medial compartments. The anterior compartment includes the quadriceps femoris and the vastus muscles, and its main action is hip flexion. The medial compartment runs down the middle of the thigh and includes the adductor muscle group. And this next image shows us the posterior view. And on this image, we can see the gluteal region on the top. So the top left, we can see gluteus maximus and medius. On the top right, we can see the minimus, a deeper muscle. And that region's main role is hip extension. Also recruited powerfully in hip extension is the hamstring group of the posterior compartment. And then the lateral rotators lie deep beneath the gluteus maximus. So they're pictured on the right half of this image. And their main job is to abduct the hip. The piriformis muscle of this group is important in certain pathologies, which Taylor will be discussing later. Next, we have how the hip is innervated, and all of its innervation comes from the lumbosacral plexus, which are 2 groups of spinal nerves. They're known separately as the lumbar and sacral plexuses. These nerves branch out to supply nerves that signal the muscles of the pelvis and down in the thigh. So the femoral nerve is part of the lumbar plexus, and it innervates the anterior thigh. The obturator nerve also branches from the lumbar plexus, and it signals the adductors in the medial thigh. The gluteal nerve comes from the sacral plexus to innervate the gluteal region. And last, we have the sciatic nerve of the sacral plexus, which innervates the posterior thigh and parts of the lower leg. Because the hip joint is a ball and socket type joint, it can be moved through a wide variety of planes and movements. In the sagittal plane, typically the hip can perform 0 to 30 degrees of flexion, which involves bringing the thigh towards the front torso. and 0 to 30 degrees of extension, lifting the thigh behind the body. In the frontal plane, the hip can abduct 0 to 35 degrees away from the body and adduct 0 to 30 degrees across the midline of the body. In the transverse plane, the hip can internally rotate 0 to 45 degrees, turning the thigh and knee in towards midline, and it can externally rotate 0 to 50 degrees, turning the thigh and knee outwards. The pelvic girdle can also rotate in the anterior, posterior, lateral, and transverse directions, and typically does so to accompany the motions of the hip. In research analyzing the kinematics of various hip actions and range of motion in daily life activities, all of the above movements were utilized, but out of all the movements, hip flexion appears to be the one used most frequently and moves through the largest range of motion, and it is therefore very important for functionality. Shown here are my references that I utilized for both the informational content and the images in this section. Next, Michaela will be discussing a common hip injury among older adults, which is hip fractures. Thank you.
Okay, so my name is Michaela McGuire, and I'm going to be talking about hip fractures today. More specifically in the older population. I know that this does happen in younger people, specifically ones in sports, but we are going to be talking about the older population throughout this. So to start off, what is a hip fracture? Basically, it is a break to the upper portion of the femur. This can be life-threatening. It can be very severe. It just depends on the type, which we will go over the types throughout this. And also, most of these fractures do occur in patients that are 65 and older. So, relevance, as you do age, the risk of getting a hip fracture does increase, mainly because your bones are getting weaker throughout time. If you do not take the preventative measures, this can get a lot worse as you get older, and we will talk about those preventative measures in the upcoming slides. It is important to take these measures just to ensure your bones are going strong and healthy. So some of the common symptoms and signs for this in our older population is an inability to get up after a fall. This is why balance assessment is super important when we're talking about getting that exercise. That's another key part to that. There will be a lot of bruising and swelling that shows up in the hip region. You'll also experience severe pain and an inability to apply weight to that injured leg. Depending on the fracture, there can be an outward turning of the leg, and a lot of these symptoms will depend on how bad the fracture is, its location, and that kind of thing. Some of these symptoms might not show up in all of them, but they are prevalent in most. So we have 5 different types of hip fractures. We have a fracture of the femoral neck, an introchanteric fracture, a fracture of the greater trochanter, a subtrochanteric fracture, and a femoral head fracture. And I'm going to be talking about all of these in detail in just a second. So the first one that we're going to talk about is the fracture of the femoral neck. This area is considered the weakest part of the femur, so it is more subject to those fractures. The fracture in this area can be pretty severe since the blood supply to the femoral head depends on that type of fracture. And there are 3 types associated with this. There's a subcapital, which is a fracture to the femoral head or the neck joint. There's a transcervical fracture, which is a fracture to the middle portion of the neck. And then there's a basis cervical fracture, which is a fracture to the base of the femoral neck. The subcapital and the transcervical are considered to be intracapsular fractures, meaning it's directly in that hip joint. That's where the fracture is located. And then the basis cervical fracture is more of an extracapsular fracture. When I was reading about this, there was a lot of controversy with this one. A lot of people say that there's some intracapsular and some extracapsular, but for the most part, they consider it an extracapsular fracture. And once you get your x-ray or an MRI, you can really tell which one it is. It can also be displaced or non-displaced. Since there's a high risk associated with displacement, it needs to be monitored and making sure that you are going to the doctor, getting it checked out, and they are x-raying you and doing that kind of thing because of that blood supply that we did talk about. With displacement, if the fracture does not heal, it could lead to avascular necrosis, and this could cause damage to the cells that are in the femoral head. Most often, displaced fractures are treated with hip replacement because of the risk of avascular necrosis. And here is a picture of a fracture to the femoral neck. As you can see right there in that neck, it has been fractured all the way across. And then here is an actual x-ray, and there are arrows pointing to that region. And then next, we're going to talk about the intertrochanteric fracture. This occurs between the greater and lesser trochanters below the femoral neck. And on the next slide, I have a picture of that to show you exactly where that is located. This accounts for 38 to 50% of all hip fractures. It can be either stable or unstable. When it's stable, it means that it is broken into 2 or 3 parts, and unstable means that it's broken into 4 parts or a reverse oblique pattern. For treatment, typically it's surgical. They'll put a hip screw on the outer side of the bone, and a lag screw is used to place through the femoral head and neck. And this essentially will increase the stability, and it promotes healing in that region. And here's the picture. As you can see, it is right there between the greater and lesser trochanters. And in this picture, you can also see that screw that is being used to hold that into place. Next, we're going to talk about fracture of the greater trochanter. So this area is the bony prominence on the lateral aspect of the femur, and it's an insert site for both the hip abductors and external rotators. So it's especially painful with adduction and extension because of this. It typically happens during a low energy household fall. And the next fracture that we're going to talk about happens through the same kind of way. And these two are the ones that you'll most likely see when it comes to our older population and hip fractures. It's typically non-surgical, and weight-bearing exercises or activities must be stopped for most of the time a month, but it can be longer depending on the severity. And then here is that picture. As you can see, the greater trochanter has chipped off right there. Next, we're going to be talking about the subtrochanteric fracture. This one is below the hip joint on the upper part of the shaft of the femur. Like I said, this one is also a low energy household fall. It's very common in our older population. This one is surgical. They take an intramedullary nail and place it into the shaft and then put a screw through the femoral head. And in this picture, you can see that it's right there at the top of the shaft of the femur, and in this picture it has arrows pointing to that specific region. Next, we're going to talk about femoral head fractures. This is the rarest type of fracture. It accounts for about less than 1% of fractures. This one typically doesn't occur in our older population. It's mainly younger people who either play sports or got into a car accident or something like that. It can either be displaced or non-displaced. If it is displaced, then surgery is necessary to have the fragment removed. But if it is non-displaced, then it may not be surgical. You would just need to limit your weight-bearing activities. And then there's that picture. As you can see, the top of the head has chipped off. This one would be considered a displaced fracture. So here are some preventative measures for hip fractures. You need to increase your calcium and vitamin D intake. Calcium helps to make those bones healthy, and also our bones are the main storage site for calcium. And then vitamin D is needed for calcium absorption in the gut. Also, weight-bearing exercise and balance assessment, as I talked about before, is extremely important as you age, because exercise will make your bones stronger in the end. And then balance decreases as you get older, so maintaining relatively good balance will help you not to fall. And then it's also recommended to avoid substances that will impair your function. This includes alcohol or certain types of drugs. This is mainly just to keep you from being in the position to fall. And then here are my references. And then next, we're going to have Taylor. Thank you.
Sorry. Hello, my name is Taylor Dorsey, and I am going to be talking about the etiology of piriformis syndrome, and just going more in depth about the syndrome itself, and talking about what muscles are effective, and just giving a little history on it. So first, I'm going to be talking about what is the piriformis muscle. So first off, it is a flat pear-shaped muscle located in the gluteal region of the proximal thigh. It is one of the 6 short external rotator group muscles in the gluteal region, and that group of muscles contains the piriformis muscle, the gemellus superior, the gemellus inferior muscle, the obturator externus and internus muscle, along with the quadratus femoris muscle. I'm sorry if I pronounced that really weird. The muscle abuts the posterior wall of the pelvis and the posterior wall of the hip joint. Right here is a picture of all the 6 short external rotator group muscles. So as you can see right here, here is the piriformis muscle right here on the top. And so the gemelli superior muscle is going to be located at the bottom. So as you see, it's superior to the gemellus inferior, which is located at the very bottom. The obturator internus muscle will be located in the middle along with the externus and the quadratus femoris. And they're located at the very top and work close together to help with the external rotation of the hip joint. Next, I'm going to be talking about the overall function of specifically the piriformis muscle. It works to rotate the femur during hip extension, and it also abducts the femur during the flexion of the hip. So basically, whenever we walk, the function of the muscle is to help shift the body weight to our opposite side while we walk, so it can prevent us from falling. So basically just to help us with our balance overall as a whole. So the muscle also divides the foramen into a superior and inferior segment, and which helps name the nerves and vessels in the gluteal region. So overall, this muscle is the only muscle that courses transversely through the greater sciatic notch, and it is also the key landmark to the important nerves and vessels that pass from the pelvis region to the gluteal region. Sorry. Now I'm going to get more in depth into the actual syndrome itself. So overall, piriformis syndrome is the compression of the sciatic nerve by the piriformis muscle, and it is caused by excessive contraction of the muscle. It is also a common cause of sciatica, which is overall leg pain that goes straight down from your leg. It starts from your low back and then goes all the way down to the bottom of your foot in most cases. It is the common cause of buttock pain, external tenderness over the greater sciatic notch, along with aggravation and pain that comes with sitting down, and it is highly common in the elderly population. Piriformis syndrome is also pain felt, like I said before, in the leg with the distribution of the sciatic nerve accompanied by low back pain. Right here, I have an overall image of kind of the anatomy of the piriformis muscle. So just another image I have to be more specific. So located up here is the piriformis muscle. And then right below here is the sciatic nerve. To the right of the piriformis muscle is the gluteus minimus. And right below that is the greater trochanter. I'm sorry if I pronounced that weird. So I'm going to be talking about relations between the piriformis muscle and the sciatic nerve. So the sciatic nerve begins with the pelvis, and it leaves it by passing through the greater sciatic foramen below the piriformis muscle. So it's going to be located in between the two. As you can see, I don't know if my mouse will be covering that image or not. the contractions of the piriformis muscle on the certain area of the sciatic nerve is what contributes to the piriformis. So it could be contractions of the nerve or the compression that will cause that hip pain, that lower gluteal and back pain that will contribute to the syndrome. And then here are my references. And then here is Kelsey.
Hi, I'm Kelsey. I'm going to be covering hip dislocations and kind of just concluding like the whole presentation that the other ladies have said. So the hip is a diarthrodial joint that maintains its stability with the combination of bony soft tissue constraints. The incidence of hip dislocations and fracture dislocations is increasing with, it's occurring most in young adults, and it's as the result of high energy motor vehicle accidents. It's actually a substantial force is required to dislocate dislocate the native hip joint. The damaging force can be coupled with young age at disease onset, and it can lead to prolonged disability and dysfunction from complications such as osteoarthritis and osteonarcosis. Like I said, hip dislocations are actually pretty uncommon. They represent only 5% of all traumatic joint dislocations. I'm not even on my first slide. I am so sorry. Whoops. Like I was saying, they're uncommon injuries. They represent only 5% of all traumatic joint dislocations. The majority of hip dislocations actually occur in males between 16 and 40 years of age, and they are a result of motor vehicle accidents. It has been reported that 70 to 100% of posterior hip dislocations result from motor vehicle collisions. Hip injury is classified based on the direction of displacement of the femoral head in relation to the acetabellum. Hip dislocations can be divided into two categories, so you have simple and complex. Simple dislocations do not have an associated fracture, so they are ones without fracture of the proximal femur or acetabellum, and they are less common. Complex dislocations have associated fractures that involve the acetabellum, the femoral head, or femoral neck. So whether a hip dislocation occurs with or without a fracture of the acetabellum is largely dependent on the direction of the femoral head at the time of injury. They also, you can look at a hip dislocation from an anterior or a posterior point of view. I will talk more about that in a second. The mechanisms of the injury, so the depth of the acetabellum and the labrum, which is the thick joint capsule and the strong muscular structures, make the hip a true ball and socket joint, and it's unlikely to dislocate. So anterior hip dislocations, they represent 10% of all traumatic hip dislocations. The anterior ones can be subdivided into a superior type, which is 10%, and an inferior type, which is the 90%. The superior type is caused by abduction, external rotation, and extension of the hip. They can even be further divided into three categories. That is either obturator, pubic, and iliac. In obturator dislocations, the femoral head can be seen overlying the obturator foramen on if you have like an AP pelvic radiograph. And then the position of the femoral head determines whether the anterior dislocation is termed pubic or iliac. The inferior type is caused by forced abduction, external rotation, and flexion of the hip. That's all for anterior. Posterior dislocations, they are caused by forced adduction, internal rotation, and some degree of flexion of the hip. Increased flexion and adduction is more likely to cause a simple dislocation. Femoral anteversion may predispose patients to simple dislocations. So in this picture, I have a hip dislocation. Image A on the left is a posterior hip dislocation, and image B is an anterior view of a hip dislocation. I put a classification system on this slide. It's the most widely used classification. It's the Thompson and Epstein, and then Stewart and Milford. So the Thompson and Epstein classification they are of posterior hip dislocations, and it includes associated fractures for types 2 through 5. There's a couple other ones that aren't widely used, but the Pipkin classification system is used for posterior hip dislocations associated with femoral head fractures, and then there's 11 classification, and it can be used for both anterior fracture dislocations and posterior fracture dislocations. This slide has a treatment algorithm. It did. If I can go back, there it is. The 3 main types of treatment for hip dislocations is open reduction, closed reduction, and arthroscopy. I updated my notes, so it's not on here. So closed reduction is the most preferred, and it's wanting to be done 6 hours, like within the injury. And then if it isn't performed within 6 hours, that's when they have to either do open or the arthroscopy. That is the more intense treatments. So with hip injuries and hip dislocations, they have associated injuries. So like I said, hip dislocations are present after high energy motor vehicle accidents and have a very high likelihood of associated injuries, either systemic or musculoskeletal. Other complications of hip dislocations include osteoarthritis, osteonarcosis, and sciatic nerve injury. So the sciatic nerve injury is as the femur is pushed out of the socket, particularly in posterior dislocations. It can crush and stretch nerves in the hip. The sciatic nerve, it extends from the lower back down the back of the legs. It's the nerve that's most commonly affected from hip dislocations. Injury to the sciatic nerve may cause weakness in the lower leg and affect the ability to move the knee, ankle, and foot normally. Sciatic nerve injury occurs in approximately 10% of hip dislocation patients, and the majority of these patients, they will experience some sort of nerve recovery. Osteonarcosis, also called avascular narcosis, is as the femur is pushed out of the socket, it can tear blood vessels and nerves. When blood supply to the bone is lost, the bone can die, and this is what results in osteonarcosis. It has been reported in 11 to 34% of hip dislocations, and it depends on the severity of the injury. It's a very painful condition, and it can ultimately lead to the destruction of the hip joint and arthritis. So osteoarthritis is when the protective cartilage covering the bone is also damaged, and this increases the risk of developing arthritis in the joint. So the arthritis can eventually lead to the need for other procedures like a total hip replacement. I know osteoarthritis is more common in the elderly. That's when most older people, they might have had a total hip replacement. This is just when their hip dislocation, their hip fracture, it wasn't properly taken care of, and it has led to a more serious procedure than they probably would have hoped for. The rate of coxarthritis following hip dislocations is between 24% for simple dislocations and 88% for those associated with acetabular fracture and complex dislocations. Associated morbidity is compounded by the presence of other systemic injuries, which occur in approximately 40 to 75% of cases. There is a 95% incidence of injury to other areas of the body in patients with dislocations. Acetabular fractures were seen in 70% of patients with traumatic hip dislocations, other lower extremity fractures in 23% of patients, upper extremity fractures in 21% of patients, closed-headed injuries in 24%, thoracic injuries in 21, and abdominal injuries in 15. I know people think like a hip dislocation is not serious, and at the time being, people might not think it is, but if you don't get it properly taken care of, this is what your future could look like. To kind of sum everything up, I know we focused our presentation on an age range that does not particularly affect us now, but it is still important that we understand these types of injuries and diseases that can come about as we get older. All of us are gonna get old. It's inevitable, it's gonna happen, and we need to understand how these injuries can come about and how to try to prevent them as we do get older. Hip dislocations are more common in males from motor vehicle accidents, and I think that's just the statistic only stems from a stereotype that males do tend to drive a little more reckless when it comes to that. They drive motorcycles, women are a little on the more careful side, but that doesn't mean that females are excluded from these statistics. Injury to the hip can have a lot of consequences, and I'm very confident in saying that nobody wants to get to the age where these diseases and injuries happen, and we want to be able to use our legs when we get older. So we need to learn about them now. We need to learn their prevalence so we can take important measures. Working out, eating healthy. I know Michaela mentioned that. We need to take those measures at this age so the onset of these injuries and diseases can be delayed as much as possible. I know as far as hip dislocations go, it's not really, they really cause from motor vehicle accidents. So really just driving safe, wearing your seatbelt, that's really important for us to do now, as well as the working out and eating healthy. I know males do have a tendency to drive more reckless than females, but like I said, that doesn't exclude females in our age range to have, not have hip dislocations. We are just as likely to get in a wreck, get in an accident, someone hit us. So if we start working out, eating healthy, getting those vitamins and minerals, hopefully our hips can withstand some traumatic force. Here is my 2 reference pages, and that sums up our presentation. Thank you.